Hello, good afternoon, good evening. Thank you so much for joining us tonight. My name is Marta. I'm Operations Director of London Egg Bank. And today's session is all about what does it mean if selected donor is a carrier. I have today with me two great UK fertility experts. Dr. Nair, who is our clinical director, and Mr. Summers, who is an expert in the field, and both of them has been working in fertility field for many, many years. They will introduce themselves slightly later on. We prepared for you short slides to introduce the topic. This webinar topic is all about genetic screening of the donors, and we want to, as we are getting a lot of more questions from our recipients asking, what does it mean that the donor is a carrier of this condition or another? We thought it would be good to focus on this such an important topic to maybe answer any questions you might have. So we will have a couple of slides for you just to introduce the topic, and after that we will have question time. So you have options here with the QA. So please, any questions that you might have, please submit to us and take this opportunity that you have two such a great experts today with us. And the session we are planning to, we have 30 minutes, so I think more than enough to go fully through everything. So if that's okay, I will start by sharing our slides. Okay. I hope, sorry, that we can see them. So my donor is a carrier, or what that means for me. And like I said, we have Dr. Nair and Mr. Summers today with us. So firstly, before I let speak our doctors, for some of you that are quite new to London Egg Bank and who we are, just a very quick intro that London Egg Bank is the largest frozen egg bank in the UK. And obviously this is our speciality. We are part of London Women Clinic Group, but we specialize just with egg donations, treatment with donor eggs. So we have a very dedicated specialized team to go through this treatment options. And yes, so far very successful, more than 2,500 babies born through our services. So London Egg Bank is the only bank in the country that introduced expanded carrier screening. So in 2021, due to the work of our genetic service team, we decided to expand the carrier screening for our donors. And we took this step to make sure that we even make more like a safer and the matching service that we provide to our donors. So generally, all fertility clinics are regulated in the UK by Human Fertilization Embryology Authority. Due to regulations, there are standard screening protocols that every clinic, any donor register in the UK must go through. We go a step ahead, so we add screenings to that panel to make it even safer for you. But I will ask our doctors to maybe introduce you to this and talk more. First of all, what is a carrier, Dr. Nair?
So just want to begin with why are we testing for these genetic conditions and what is the purpose of looking at carrier screening? It's all about screening the donor to minimize the risk of the baby having any serious hereditary disease. And it starts with the history. There are various layers of screening, but today we are focusing only on genetic screening tests that we do for donors and it is. So I want to say that I have Mr. Summers, who's one of the biggest experts here. So I'm just going to give you the very basic information of what carrier screening means and what does it. What are the implications if you select a donor who is a carrier. You will have Mr. Summers to answer many more questions, if any. So I want to say to you that it is a genetic screen test, and it is used to determine if an individual carries a gene for a recessive or an X-linked genetic condition. And when you say recessive, most of us have two DNA, two strands, and you can only have the condition if both those strands carry the same genetic mutation, which also means that the donor herself having the condition is healthy, does not have the condition, and therefore she would be totally unaware, and the only reason she may be aware is because she decided to donate her eggs. But she can pass on the condition to the children if the sperm provider, her partner, recipient's partner, is also a carrier of the same condition. So I want to add by saying that most of us carry. Michael, do you want to add anything, or shall we go to the next slide?
Well, I think I would just comment that the human genome carries about 35,000 genes. That's how many genes are needed to make a human being. And because there's a large number of genes, most individuals carry anywhere from 3 to 4 genetic mutations without knowing about it. When we do our screening, we are mainly screening for the most common genetic defects because they're the ones that are at highest risk for both partners to be carriers. So we're not sequencing the whole genome and looking for every possible gene mutation, but we're being highly selective for those high-risk genetic diseases. So,
thank you. So, Marta, we go to the next slide, please. So, as Mr. Summers mentioned, being a carrier is not uncommon. In fact, most of us carry many mutations, as you rightly said. But what we're looking to do is, unlike couples getting pregnant naturally out there, where many couples don't screen for these additional screening tests, because of the fact that it is fertility treatment to maximize or minimize the risk of the child having any inheritance and maximizing chance of having that healthy baby. We do these additional screening tests well beyond the UK egg banks and closer to the European egg banks. So screening is because we are looking at selecting an egg donor. We want to make this as the safe and as again, it's all about the welfare of the child. So this is the reason why we screen, and this is the reason why we screen recipient partners or counsel if you select a donor who is a carrier. So I think we could go to the next slide. I think, Michael, this is probably just basic. Yeah. So again, I'm sure Mr. Summers, you may want to add something, but I want to just say that these are the common recessive traits that we screen for, because we are not, again, testing for every known mutation, but only the common mutations. So cystic fibrosis, 1 in 22 of Caucasian population, alpha-beta thalassemia, more common in Asian populations, sickle cell, more common in the African population, Tay-Sachs, with those having a Jewish, inheritance, and spinal muscular atrophy, I think, is 1 in 50 of Caucasian. So we are testing for the common mutations and saying if you select a donor who has these common mutations, you would be looking again to minimize the risk. And I think, Michael, if you would like to add anything further, please do.
No, I think that we have to use a common sense approach to screening because, as I mentioned, most people carry 3 or 4 mutations. So if we were to screen for every gene, then we'd be constantly testing every gene in both the partner and in the egg donor. And this is just not practical. But I think we're trying to find the right balance between safety and common sense and effective screening for all our patients when they're choosing egg donation as their form of treatment.
So the chart on the right side talks about what are the implications. So if you select a donor who is a carrier, but the sperm provider is not a carrier, there is a 50% chance that the child would be a healthy carrier like the donor. However, if the recipient, or I mean the sperm provider, is a carrier, then there is a 25% chance that the child could have the disease. Although, of course, you might say there is a 75% chance the child would not have the disease, but 25% is quite significant. And there's a 50% chance that the child could be a carrier. So that is really the implications, and that is really the basis of testing the sperm provider for any of these mutations that the donor might have. So, Marta, if you go to the next slide, we don't have too many, I think. Yeah, so this is exactly what the implications are. We have a genetic counselor who, in addition to this, the general information, would be more than happy to have a more personal discussion with you if you select a donor who is a carrier. So if, once again, we do not charge to screen the sperm provider for the specific genetic condition. In fact, we ensure that the sample is sent to the same lab where the donor is screened, and therefore the mutations that we screen for are the mutations that the donor has been screened for. And if the sperm provider is not a carrier, the risk to the child is extremely low. There is always a residual risk, and there is only so much that technology can take us, but it is as low as possible under the present our abilities to test. But if both sperm provider and the donor are carriers of the same condition, we would offer an alternative donor. That is basically what the screening is all about, and this is basically the follow-up in case you select a donor who is a carrier. Michael, anything further?
I think I would just add that there might be that very, very rare situation where the couple truly want the donor that they've chosen, and if the male partner happens to also carry the same mutation, then in theory one could offer, using that particular egg donor, one could offer PGT, molecular testing, because at any one time, only the risk having a child with the disease is 25%. There's a 50%, as Dr. Nair mentioned, there's a 50% of being a carrier themselves, any offspring. But the main risk is the 25% risk where the child inherits both mutations from the male and the female. So you could, in theory, do PGT in molecular testing to rule out that 25%. So that's always an option, but obviously the simplest route would be to simply change the donor if the donor happened to be a carrier and the male partner also a carrier of the same genetic condition.
So I think that covers our presentation. We are now open for questions.
Yes, thank you so much. I just want to add to one thing. Obviously, for any PGT, we will need HFEA sort of permissions. And I think there's also not every you can screen. So there will be complications. So we definitely wouldn't advise that. But now we have some options for the questions from the public. If there is anything, please, if you can submit to our QA session or raise a hand if you want to speak, but we would prefer to receive the questions. So far, I don't see any questions, Dr. Nair, Mr. Summers, so I I guess that we covered everything. Let me see. No, we don't have anything. So generally, Dr. Nair, I will start with you. If you having your recipients, are they sometimes like, oh, we have we have questions coming. But I just wanted to say, are generally your recipients asking you about that with the selection of the donor or not really? Is it something that now in the population is a little bit, because I remember when we started Egg Bank 10 years ago, there was a little bit different perception of being a carrier screening because those tests were not that common. And now I think because a lot of sperm banks and others introduced this screening, it's become that there's a more awareness of what Mr. Summers says. What does it mean being a carrier, that we all carry some genes?
Yeah, I would think that today the most people are more informed than maybe 15 years ago, and the degree of anxiety is far lower. Of course, they do understand the implications there, but I don't think there is a degree of anxiety, and many of our donors who are carriers are selected as frequently as those donors who are not carriers. Ultimately, once again, this is an additional layer to minimize the risk. And I think recipients know that there is a large screening protocol that we do to reduce the risk. And this is one of the major of our screening tools, as it were. So I would agree that today most recipients don't seem to be unduly anxious.
Summers, we have first questions. So the first participant is asking, if we were to choose a donor who is a carrier for cystic fibrosis, will the sperm genetic test delay the process? How long could this take?
Well, I believe that the testing for that group of genes that we use, if you did the same testing on a sperm sample, it would take just a few weeks to get the result back.
Yes, but we would mostly do them on saliva kit or the bloods. I think we don't need to test sperm because usually, yeah.
You can just do a buccal smear, or that's the most common way nowadays. It's very rare we do blood samples nowadays.
Well,
I think we should add that the LEB would take the cost of that because this is part of our screening process.
Yeah.
But the sample has to be sent to a lab in Spain.
So we would do like the swab test, and then from the cheek or even a saliva we can send. We have a lot of patients coming from abroad to us. So sometimes the laboratory we use will send like a kit to them. They can do it at home. They send them back the kit, and then within like a couple weeks we have results of the matching. And what is good with this test, that once you do the test, obviously, then it's open a pool of a lot of more donors for you, because there will be quite a lot of donors that they are carriers, but until you do this test, we will not kind of recommend being matched to them. So we can also like do that. So it's quite good, and it's free of charge. So there is really no. And another bonus is you get to know a little bit more about yourself, because you will get this test and you will know whether you are yourself a carrier or not.
Yeah, I should mention that the testing lab does send a lot of information on the carrier risk and how it changes if you're a carrier or not a carrier in terms of any future child. But I think the buccal smear is probably the most widely used now. I mean, when we send samples to our testing lab, the reason that we use blood is because we also do a carrier type as part of the testing, which you don't need that if you're testing for a single gene or a small group of genes. A buccal smear would be more than sufficient.
So another I have a question, Dr. Nair, for you now. How do you screen for serious mental illnesses? Is there, I don't know, a blood test, swab test?
No, there is no screening blood test for mental health disease. And a lot of our screen tests, and that includes mental health, is based on very stringent family history taking. And so we're looking at 3 generations, maybe 4, with starting with grandparents, parents, siblings, and the next 4th generation, nieces, nephews, children. Well, we do not exclude donors with clinical depression, often, and because that's usually environmental, but we would exclude donors with a history of psychiatric conditions, including schizophrenia and bipolar depression. Now, our donors tend to give a lot of information, and I have, over the many years, I found donors eager to give as much information as they can, given that this is an altruistic program, and they're driven, motivated by a lot of a good altruistic intent. We have a genetic counselor, and who may go through a more detailed family history if it's not clear whether the risks are significant or not. Now, we look at less than 5% risk as the background risk that any human being, out there getting pregnant naturally with healthy parents could have. So there's always de novo mutation. Something can happen at the time of conception where neither parent had that condition. So we talk about less than 5% risk as the background acceptable risk out there in the population. But if it's above that, we then would not accept the donor. So when you say serious medical illness, there is obviously psychotic or psychiatric conditions would be different from clinical depression. Well, now I would like to add that all our donors have a GP letter sent out. There is a safeguarding letter that we sent out to the GP. Since all our donors are UK registered. And if there's anything there that is significant, it's always highlighted. And there are 2 things, of course. One is the welfare of the unborn child, the risk of inheritance, and what are the risks to the donor herself, any safeguarding risks to her if she puts herself through an egg donation cycle. So we look at both.
Thank you so much, Dr. Nair. And Dr. Summers, I have another question. If I want my baby to be healthy, why should I choose someone with one of these conditions?
It's an interesting question, but the evidence we're mainly concerned here with what are called autosomal recessive disorders. Because the other type of disorder is an autosomal dominant. And of course, if we were concerned about that, then the donor themselves would have the condition. So we're only interested in autosomal recessive conditions. As Dr. Nair mentioned at the beginning of this presentation, we all have 2 copies of every gene, and you only need 1 copy to be normal. So it raises an interesting ethical issue if you start discriminating against women who have a single gene disorder, right, with one mutation, but they don't have the disease. So that would be a form of, I think that you'd get into very difficult ethical grounds if you started making decisions about women who are carriers versus having the disease. So we treat carriers along with women who have no disorder at all, exactly the same. So because they don't have a disease, therefore there's nothing to select against.
Yeah.
So it comes down to really about the rights of the individual to be a donor or not be a donor, and we could not discriminate under the UK regulations a carrier of a genetic condition because they are fundamentally normal.
Yeah, and also obviously, like you mentioned, if we would do excessive screening of 500 different mutations, we wouldn't have a single a donor who wouldn't be a carrier of something like you have in US or other places, because I think knowing that the donor is a carrier make it safer, because then recipients can be tested. But Mr. Summers, I think the main question here is from someone who is looking to be a mother. Obviously, the welfare of the child is very important. So I guess patients want some sort of reassurance that selecting these donors, which already are marked somehow as carrying something, will definitely give them this, that if the sperm provider is tested, the child will be healthy. Because that's the fear of unknown, that's a fear of something already there on the profile.
Well, I think that with the genes that we're screening for, there is no evidence that being a carrier is detrimental. In fact, you could take the view that cystic fibrosis, for example, a carrier status, is very common amongst the Caucasian population. So one could argue that it actually represents an advantage to carry one mutation. In other words, why does the condition persist if it's being selected out by doing gene testing and things like that, when it's the same rate it's always been within the general population, so it has not been selected out, that condition. So one could argue that potentially it offers some advantage we're not aware of.
I think, Michael, if you look at the sickle cell carrier, I think they're protected against malaria, isn't it? There's a high
in the case of sickle cell disease, it does protect against the deadly disease malaria. So that's why it persists in the general population, because the malaria does not have a destructive effect on those individuals. And so there are probably a lot of cases where single gene disorders offer growth advantage or some other advantage that we don't fully understand.
Yeah, so we not try to eradicate something that the nature has, all of us has. And if you meet somebody who's your partner, you will not do genetic testing, because who is doing those? Almost nobody. I think this is very important, I think, for patients to understand that we're adding this extra layer because, of course, you come to us and it's our duty of care. And we cannot have even the small percentage of chances. But yes, also another thing, I remember before 2021, so we adding some extended screening now, so let's say SMA, or even like we were testing for more mutation for cystic fibrosis. And I remember myself, the donors who donated with the old protocol, they were found as not being carriers. And then they came for another donation cycle with the new carrier protocol, and all of a sudden they become a carrier. Could you explain this to the patients as well, please?
Well, certainly the gold standard is the cystic fibrosis gene. It's actually the cystic fibrosis gene is the largest gene within the human. In terms of the length of DNA that's actually coded for the gene itself. So in the early days, and I can remember going back, because I was based in London at the time, the active research that was going on to actually isolate the cystic fibrosis gene. Eventually it was done by a group in Canada, but there was a lot of interest in the London area for isolating the cystic fibrosis gene, mainly because it's so common. But at the early days, it was a matter of finding gene changes within the cystic fibrosis gene that were actually pathogenic. So not only do you have to find a difference within the gene, you have to then demonstrate through a lot of clinical studies that that gene actually is pathogenic. And so that's why it's taken a long time. Yes, when I first came back to the UK 15 years ago, right, the cystic fibrosis testing was 32 mutations. No, it's 132 mutations that are searched for that are known to be pathogenic mutations. And some have stronger effects in others. And sometimes you can get combinations of effects depending on the mutation. So there's a whole field now, and that's just on the cystic fibrosis gene. But the same approach is used for all other genes, but it takes a while to build up a knowledge base to actually genuinely say, this is a new pathogenic mutation and just not a benign variant within the gene. So that's why it changes with time.
Oh, do I understand correctly? So I could test myself now, and let's say the laboratory will tell me you are not a carrier, but then they could retest my DNA in 10 years and say, actually, now you are a carrier because we discover that this is a pathogenic variant.
Yeah, it's good. It's that particular gene is so widely studied that they might find some combinations in the future, but the Illumina testing gene mutation testing system is extraordinarily robust. And I think the 132 mutations have been available now for about 8 years, and they haven't added any new mutations over the last 8 years or so. But yes, it's always possible that you could get two benign variants that together create a problem. So, right as of today, they screen for 132 known pathogenic mutations.
So I have still a question, probably before sent. So could you again reaffirm patients? My husband has been tested and a gene mutation found. We are using an egg donor. Just to clarify, this is safe as long as our donor does not have the same mutation, right?
Yes, I mean, it's a matter of you have to test the whole gene because you can get different mutations within the same gene. So there might be combination effects by having different mutations, but within the same gene. But normally, what's done is you test for that particular mutation, but you also, because you're doing DNA sequencing, you can also find other potential mutations within that gene. But quite often, for example, even with cystic fibrosis, right, the most common mutation, even though there are hundreds of mutations now, within that gene, a third or a half of the mutations are the same mutation as the so-called delta F508 gene site. So they still make up the bulk of the mutations in cystic fibrosis. And the same thing would hold true for most other mutations in other genes. But you would sequence the whole gene. If you knew someone had a gene mutation and you wanted to test the partner, you would, or the egg donor, you would have to do it through DNA sequencing just to be absolutely certain.
But once again, sorry, Mata. But given that we have such a large database of egg donors, and of course we have a large number of donors who are CF negative, it might just be a little safer to just not, just to select a donor who's not a carrier, because I would think that today we have such a wide selection. So that is probably an easier and quicker route.
But I'm sorry, Dr. No, we don't know what mutation it is. So the lady just said that her husband is a carrier of a mutation. So she's asking if we test a donor and donor is not a carrier, would it be safe for the child? So she's more asking to get reassurance that those kind of tests are possible, and obviously they can still have a healthy child.
Indeed. Yes.
Yeah, I think you can be very confident because de novo mutations of autosomal recessive disorders are fairly rare. So you can never rule out a de novo mutation in any gene, but overall they are very, very infrequent.
think you need to explain what means de novo mutations, Mr. Summers, because we probably have audience that's not familiar with all this terminology. So what does it mean? So even if you like, what is de novo mutation?
Well, at any one time, let's take the cystic fibrosis gene, for example. You could have parents who have no mutations, but during the early embryo development, a mutation did occur within the cystic fibrosis gene.
Mm.
That has to happen because that's why it persists in the general population.
Okay, so two non-carriers, they still can have a child, and this mutation will start with the child.
It would be a de novo mutation
Okay.
in the child, and we see that very often with autosomal dominant disorders, where neither parent, because you would know by looking at the parents if they had a autosomal dominant disorder, we would know very clearly that the parents aren't affected, but the child did have, and that happens in natural conception. So it's got nothing to do with doing IVF. It just happens to happen in the DNA. One random event.
Okay, so let's maybe leave this because we are making, I think we're opening a lot of different boxes, but it's just to kind of like, I think, to make realize to our patients that what we do is safe. It's even safer than if you will be doing like conception out of IVF clinic. And then obviously the testing give this reassurance, but at the end of the day, there's still chance that any sort of mutation and thing can happen, but it's very, very, very rare. So
That's that,
another,
that
yeah,
that's correct.
yeah.
I mean, we are, I mean, at the end, not to confuse people, but we are simply willing to go the extra mile because we're focused on the welfare of the child. I mean,
Exactly.
fundamentally, that's what we're doing.
Yeah, that's the message we want to kind of say. Um, so what is the process? So generally we said it will be a couple of weeks to test the partner, and if they so because a lot of people asking the process, or maybe I from like operational side will say, so if you select a donor who is a carrier, we will do, of course, you will have genetic consultation to explain that, what test we would do for the sperm provider so they can consent to it. We straight away do the test. It takes a couple of weeks. We have the results, which will be assigned by the doctor and genetic team, and then straight away you provided with results. If you are not a carrier, then straight away there's a match, you can start your treatment. If you will be a carrier, then of course we would know and we will try to offer you a donor that is not a carrier. And obviously we have a personalized matching service, and we can we have more than 300 donors, so there shouldn't be any shortage of the great match for you, and we can help you. So the process is relatively fast. It just depends how selective you are with the donor characteristic. And couple of last questions because we're just going a little bit over our time. And one lady is asking Dr. Nair that she's using a donor egg and donor sperm. Should she choose same or different blood group, blood type?
It makes no difference, medically speaking, because if you are Rh negative, that means you will need to take anti-D immunize. It's an injection to prevent you producing antibodies against the blood cells of the baby, but it has no medical significance whatsoever. So feel free to select any blood group. It doesn't matter. It's not a genetic condition, obviously.
So the lady doesn't need to match her own blood type. It doesn't matter, and can be taken by her midwife after. Okay,
Indeed.
Perfect. Another quick question. So, would you test sperm provider for only that condition or something else? Yes, we only test for, so you select the donor is the carrier of the test. We test for the same test for you. So that's we do free of charge. If you want to do excessive genetic screening, you can do with us as well, but then you will need to pay for them. And the last Questions I will pass to Mr. Summers. Again, blood. Should the egg donor have the same blood type as the woman undergoing embryo transfer? So it's very similar. Is
Yeah,
there
doesn't
statistic that
doesn't
the
matter.
embryo will implant better or no?
No, it's all about the Rh factor, and that doesn't happen until the fetus starts making its own blood, and then you worry about later on in pregnancy. But it's a very simple treatment. If one is Rh negative, the other Rh positive, you just simply take RhoGAM at 28 weeks of pregnancy and at the time of delivery. That's all you have to do.
Thank you. This is very recurring actually question, I think, because of the Spanish bank that they advise this, but this is more anonymity issue, not the health. So I think it's confusing patients. Thank you so much for such an informative webinar. I hope our participants got all the answers. Our PCC and matching team will be sending emails after the session tomorrow. So if there are any more questions, we can always pass to our doctors. Thank you again. I hope you have a lovely evening. And thank you so much, Dr. Nair. Thank you, Mr. Summers, for being with us today and offering your expertise. Thank you. Bye.
Happy to participate.
Thank you. Bye.
Okay. I think it went well for the first time.